Good afternoon, ladies and gentlemen. It's extremely with pleasure that I hold this meeting today because I have two very distinguished visitors. The first is hardly a visitor. It's Alfonso Tafur that has taken over my practice, and he's a dear colleague and good friend. And he's a professor of medicine at vascular medicine at the University of Chicago and director of vascular medicine at North Shore. And what's really exciting is to have Grigoris Gerotziafas with us from France. He's a clinical professor of medicine, a hematologist by training, and he's the director of the Thrombosis Center and Cancer Vessel Biology and Therapeutics and Research Center at St. Anthony's in the Sorbonne in Paris, France. And it's very exciting to welcome both of you gentlemen, and you're about to see an absolutely fascinating treatise on the interrelationship with cancer and related systems of the body and practical implications for those interactions. And without further ado, I would like to present this video. Good day, gentlemen. I welcome you both to the channel.
Dear Professor Caprini, dear Professor Tafur, thank you very much for this honorable invitation to share with you the updates and the challenges in the prevention and treatment of cancer-associated thrombosis. Thrombosis is an accident, or thrombosis is the result of the biological activity of cancer cells? In my opinion, this is a fundamental question that we have to answer in order to optimize the management of cancer-associated thrombosis, since the data we have today demonstrate that the occurrence of venous thromboembolism in a patient with active cancer significantly affects the survival, and this effect depends on the type of cancer and the aggressivity of the cancer. Data from large epidemiological studies show that the risk of thrombosis in patients with cancers exists since the first day of cancer diagnosis and persists during the first year of the treatment in a significantly high level, and that the use of the new targeted antithrombotic therapies has a further multiplying effect on the risk of cancer-associated thrombosis, since, as you can see to the diagram, targeted antithrombotic therapies increase the risk of venous thromboembolism by about twofold as compared to the conventional chemotherapy. Why does thrombosis occur at distance from the tumor site? This clinical observation reveals probably the implications of mechanisms related with the cancer cell biology that implicate either the release of procoagulant material from the cancer cells, or the triggering of mechanisms that activate endothelial cells and the blood coagulation process in the bloodstream. Modelization studies from our group and also from the group of Anna Falanga has shown that according to their histological type, cancer cells express different amount of tissue factor and trigger with a different intensity thrombin generation in human plasma, and so we introduced the concept that of the procoagulant fingerprint of cancer cells. In addition, very recently we showed that thrombin generation triggered by cancer cells in human plasma leads to the formation of a fibrin network that protects like a shield cancer cells from, and also provides a scaffold into which cancer cells migrate, and they are moved and they are protected from the anti-cancer drugs. Moreover, we have demonstrated that cancer cells release tissue factor and procoagulant microparticles into the microenvironment that results in the amplification of thrombin generation, and also these microparticles can activate endothelial cells, rendering them procoagulant. Activated endothelial cells express tissue factor, amplify thrombin generation, and also they have altered structure. You can see here an electron microscopy photograph which shows how these cancer cells are covered by the fibrin clot shields, and this is a cell that has migrated inside the clot, and these are cells that emerge in the top of the clot. And as you can understand, these cells is very well protected against the treatments, and also these cells has a very potent procoagulant activity that probably presents a new source of amplification of hypercoagulability in the microenvironment. This is an original work that part of it will be presented in the next ISTH meeting. So, taking all these into consideration, you can understand why the ESMO guidelines recommend today the assessment of for the risk of cancer-associated thrombosis in all patients that are diagnosed in a primo diagnosis with cancer. And the ESMO guidelines propose to use the COMPASS CAT score or the Vienna CAT score for the evaluation of the risk of venous thromboembolism in patients with solid cancers, the Corana score for the evaluation of the thrombotic risk in patients with pancreatic or gastric cancer, and the Trolley score for the patients with lymphoma. And also the ESMO guidelines recommend the use of the Caprini score systematically to all patients who undergo any kind of cancer surgery except of abdominopelvian surgery, where application of thromboprophylaxis should be routinely administered to all of these patients. And also the ESMO guidelines recommend the use of COMPASS CAT score and Vienna CAT score when recidivant disease is diagnosed, or when resistance to anti-cancer treatment is occurs, and oncologists are obliged to change the therapeutic line. Now let's discuss the management of cancer-associated thrombosis in a 52 years old woman who is diagnosed with de novo stage 4 breast cancer, and she receives the recommended management of her breast cancer, which among others includes as first-line treatment letrozole and zoledronic acid. Here we have to answer three questions: which is the thrombotic risk related with the breast cancer, the thrombotic risk related with anti-cancer treatment, and the thrombotic risk related with the patient's characteristics. And in this slide you can see all the biological and the clinical data of this case. To respond to the risk for the cancer-associated thrombosis during the immediate post-operative period, the recommendation is to perform the Caprini score. And if you perform the Caprini score available in one of the websites, you will see that this woman gathers 7 points, so she is at high risk of thrombosis, and according to the recommendation should receive pharmacological thromboprophylaxis with low molecular weight heparin or with fondaparinux for a period of at least 4 weeks if we are in the status of abdominopelvian cancer surgery, or for at least 10 days if we are in the context of another type of surgery. Here I underline that the use of DOACs, direct orally active anticoagulants, is not recommended for the surgical patients in the post-operative thromboprophylaxis. So the patient after surgery is planned to receive an anti-cancer treatment. Thus we have to apply an holistic approach in the evaluation of the risk of cancer-associated thrombosis, because cancer itself is a risk factor, but also the risk is defined and determined by the time since the diagnosis and also the stage of the disease. In addition, the anti-cancer treatment is associated with the risk of thrombosis, but as you can see here, tamoxifen is more thrombogenic than letrozole, which however persists and is still thrombogenic since it is associated with a frequency of 1.5% of VT event. And if we consider that this letrozole will be given in a woman with advanced cancer and a woman that may have some cardiovascular risk factors which are also determinant for the risk of venous thromboembolism, you can understand that the evaluation of the risk of thrombosis is something more complicated than the evaluation of the proper risk associated with the cancer itself. From this point of view, and for this reason, the ESMO recommendations strongly recommend the assessment of risk for cancer-associated thrombosis using the COMPASS CAT and the Vienna score. And also the recommendations insist to provide educational materials on the cancer-associated thrombosis to the patients, because it is important to increase the awareness of the patients for the risk and also for the signs and the symptoms in order to get to get a visit to a physician as earlier as possible if the signs and the symptoms of venous thromboembolism appear. And when we apply the score for cancer-associated thrombosis recommended by the ESMO, which is the COMPASS CAT score, we see that this patient has a high risk of venous thromboembolism. We could also apply the Vienna CAT score if we had in our disposition the levels of the dimer. The Corana score cannot be applied for a very simple reason. It is not sensitive, it is not accurate for the estimation of the risk, and this has been proven by many studies until now. And in patients who are classified at high risk of venous thromboembolism, it is recommended today to start thromboprophylaxis either with a prophylactic doses of apixaban or rivaroxaban or low molecular weight heparins. Let's come back now to our patients, because she did not receive thromboprophylaxis and she was resistant in the first line of treatment, and then the physician changed to a new therapeutic line, and in this new phase of the disease in the cancer patient, in our patient, we can apply again the COMPASS CAT score, because the score was designed from the beginning to be applied many times during the patient journey in the disease. Unfortunately, these patients did not receive a thromboprophylaxis, and partial thrombosis in the right common and internal iliac vein was diagnosed and objectively confirmed, and now we have to treat both the progression of the cancer and the thromboembolic and the risk of recurrence of thrombosis, and also the acute phase of venous thrombosis. Here, I will not insist to the details of this algorithm, because it is very well known and very well described. But I will show you that there are some limiting factors in the application of anticoagulant treatment, particularly with the DOACs, which is the localization of the cancer per se. And it is well established today, and is recommended by the ESMO recommendations to avoid the use of DOACs, rivaroxaban, apixaban, or edoxaban in patients with luminal gastrointestinal cancer, and to prefer low molecular weight heparin for this cancer. Another question that we have today is, beyond the extension of the anticoagulant treatment, the dose. When these guidelines were published, we did not know if we should use the conventional therapeutic doses of the DOACs, for instance, apixaban 5 milligrams twice daily, or lower doses, the apixaban, for instance, 2.5 milligrams twice daily. This question was asked by the recently published phase 3 clinical trial, the APICAT study, which evaluated the efficacy and the safety of extensive antithrombotic therapy in patients with active cancer, and comparing the conventional therapeutic schema of apixaban, 5 milligrams twice daily, versus 2.5 milligrams twice daily. This study demonstrated that the use of the reduced dose has the same efficacy as the administration of the full dose. But the administration of the 2.5 milligrams twice daily had a significant advantage over the protection of the patients by clinically significant bleeding, as compared to the bleeding effect of the therapeutic dose of the 5 milligrams. The choice of the optimal antithrombotic drug lies on the careful evaluation of the bleeding risk, which is dictated by three predictors. First is the localization of the cancer. Second is the global bleeding risk of the patient. And the third is the drug-to-drug interactions of the DOACs with the anti-cancer therapies. So in the first two cases, low molecular weight heparin is the drug of choice over the direct factor Xa inhibitor. In the third case, if these interactions are strong between the DOACs and the anti-cancer treatment, also low molecular weight therapy should be selected. Renal function and the platelet counts are also two important predictors for the bleeding risk, which will determine the choice of the optimal antithrombotic drug. For the renal, for the creatinine clearance lower than 30 ml per minute, low molecular weight heparin, unfractionated heparin, and even vitamin K antagonists are the drugs of choice against over DOACs. For intermediate creatinine clearance between 30 and 60 ml per minute, low molecular weight heparin can be used as well as DOACs. Regarding the platelet count, the cutoff is situated at the 50,000 platelets per microliter, and according to the depth of thrombocytopenia, the intensity of the thromboprophylaxis with low molecular weight heparin, which is the drug of choice, will be determined. In the obese patients, there is no need for the obesity is not a predictor that will influence our choice of the optimal antithrombotic therapy. The elaboration of an integral strategy that incorporates the development of electronic decision making and support tools is part of the work that we are doing in our department, but also the concept of the establishment of specific outpatient consultations for specialized on thrombosis in oncology. The Clotting Club, as we called it here in our group, probably is a strategy that we have to consider and to discuss in order to improve the management of cancer-associated thrombosis. Thank you very much for your attention.
Well, I'm sure those of you that were able to watch that entire lecture were enthralled as I was, especially if you have an interest in the concept that began many, many years ago by a professor, a hematologist by the name of Oscar Radanoff. Oscar Radanoff was known with Davies to have developed the clotting cascade, and he was actually kind of offended that he didn't win the Nobel Prize for that. But that notwithstanding, he came up with 4 experiments done before the turn of the 20th century that showed the interrelationship of clotting, fibrinolysis, complement, and kallikrein systems. So in other words, the clotting system, the inflammation, the inflammatory pathways, and the immunologic pathways, normally triggered by an antigen-antibody reaction, but in this case, triggered with illness without an antigen-antibody reaction. Fascinating concept. And in that lecture, I very much enjoyed how you intertwined all of the different systems. And I loved that picture of the cancer cell, and it had the net over it of the fibrin mesh. And that was very interesting. And of course, the clinical implications that you present are very, very practical, and especially in today's world with the prophylaxis. My question for you is that you have a patient, let's say, that has had a colon cancer, they've had it resected, and they're on 30 days of low molecular weight heparin prophylaxis, but unfortunately they also have liver metastasis, so they are undergoing chemotherapy and maybe immunotherapy and sometimes radiation for the metastatic disease. When that treatment is completed, do you stop the anticoagulation on a prophylactic basis? Now, this is a patient that hasn't had a clot. If they've had a clot, then all bets are off. They have to stay on anticoagulation. But if they haven't had a clot, and now their therapy, as far as you can go, is complete, do you stop the prophylactic anticoagulants? And if you don't, on what basis do you use to continue them?
So first is the after surgery. In any case, there is a kind of a window in order to start chemotherapy or immunotherapy. So this is the moment where we have to assess the risk according to the proposed risk assessment models. For instance, if to these patients we perform the compass CAT score that works in the colon cancer, in this case, the early phase of the cancer, the first 6 months, gives a significant number of points, and the type of the therapy also. So it is easy to get the score higher than 7 that classifies the patient at high risk. So in this, because he has a metastatic disease, and also we are in the 6 months within the 6 months from the treatment from the cancer diagnosis. So it is a patient who is candidate for thromboprophylaxis.
Thank you
And
very much.
prophylaxis, according to the recommendations of the ESMO today, is first line is low molecular weight heparin, because the localization is the gastrointestinal tube. If we start with DOACs, we risk to have some gastrointestinal bleeding. So first line treatment prophylaxis is low molecular weight heparin. And the question about the duration, it will be 3 months, 6 months. Practically, we do not have evidence-based answer. What we have, or what we can do, is to reassess with the compass CAT score after the 3 months and to see if it persists, the high level persists or not.
Let me, if I may, take that duration question to the different scenarios. So now we have the patient who has had a thrombosis. We follow the API-CAT, the EVA suggestion. Now we've given this individual a bit longer of low dose prevention. And I kid you not, I mean, probably 5 times per day when I see the patients in clinic, can I stop now? Well, what do you answer? So how long do you keep them on if they're still, let's say, in immunotherapy, even though they may not be on full chemo anymore, but they still have the history of the malignancy? When do you?
Professor Tafu, if I understood well, is a catheter thrombosis, correct?
No, a cancer-associated thrombosis. They did have the clot. Now they are on the low-dose extended prevention. And then the patient comes back and asks me, until when?
The basic answer is that if it is indeed the cancer-associated thrombosis, since cancer is estimated as an active and present, we have to continue. Today, in my consultation, in my practice, I had a patient who participated also in API-CAT patient, a patient with myeloma. And we were at 4 years after the diagnosis of myeloma and the occurrence of pulmonary embolism. And she participated in CAT. And today I stopped the treatment. I stopped because she had from the hematologist confirmed disease remission, but she continued treatment with the biphasic monoclonal antibodies, which is associated with a low risk of thrombosis. So we stopped today, and we stopped with her, and the only instruction that I gave is that first somebody who thrombosis once is at risk to thrombosis again. So be aware if you have fever, if you have influenza, if you have COVID, lumbago, traumatism, and so on, situations that can act as trigger factors to start prophylaxis as an acutely ill medical or surgical patients, number one. And the second is education about the signs and the symptoms of venous thromboembolism. Otherwise, there is no need. But it was a confirmed remission.
Yeah.
If the cancer is there, if there is a progression of the disease that obliges oncologists to change the line of the treatment and so on, I would continue. Of course, by balancing the risk of bleeding, of course.
Now let's take that same scenario and let's say I was the patient and I said, "Well, I'm thrilled that I'm in remission, but I'm on a DOAC and I'm not having any trouble. I want to continue."
Yeah, you continue.
Yeah.
And and I think that when we discuss this issue with the patients,
Right. And I think the reason I ask that is because I think that today, especially in the old days, we used to be tremendously dogmatic. Here it is, take it or leave it. And now I think patient preferences play a very important role in how we approach some of these problems.
But that's a
Because,
very honest position, right? So there's some
Right,
areas in which have to admit that we are on the art of medicine and we have uncertainties.
right,
And always the patient's opinion, the person who is at risk, it matters for understanding their own biases. I
right.
have some patients who are fantastically afraid of clotting, that there's some way more afraid of bleeding, and introducing that in the decision making matters.
Yes,
and I think also that another element which facilitates our job is that the nature of the DOACs,
right,
stability of the anticoagulant effect, and also the absence of side effects and so on, and the improved quality of life that, how you say, balances the fear. It
Yeah.
is very important. I think that with the cancer patients, we are a little bit psychologists, more psychologists and less physician after some consultations, because they are living long and we are together and we are growing up together, so we can understand the fear and we can manage it with the
right.
docs.
One more thing I want to introduce here because, and Alfonso will enjoy this in a sense. I was a tester. I had a coagulation lab that I ran for the Department of Surgery. We tested 100,000 patients in 25 years. When the DOACs came along, I was very resistant. I'm not going to test. I can't deal with this. And it was only when I saw that the DOACs, because of their short half-life, had a lower incidence of fatal bleeds than Coumadin, that I finally came around. And now that I look back and I say, these new drugs, in a sense, are magic compared to what we used to have. And so that really has helped a lot in determining to be able to continue long term in some of these patients, and albeit the gastrointestinal cancers and all of this. You gave a beautiful discussion about how the DOACs now are gradually getting woven into our long-term treatments. So,
Yeah.
and
And I fully agree. I have the same experience because when DOAC started, you remember Kud Emker was saying it is impossible that we are checking glucose and we are adapting insulin and not checking the anticoagulants because we can die now by hemorrhage, but with insulin, maximum in hypoglycemia. So when DOAC started, we did the same time, D-dimers, thrombin generation, and thromboelastometry modified with low tissue factor concentration.
right, right,
So, and the measurement of the concentration, anti-10A activity, rivaroxaban or apixaban concentration. So since 2010, all our patients on DOACs systematically, every 3 months, we have a huge database.
yeah,
So from 2010 until today, I did not change one dose.
wow,
And when I look backwards, the effect of thrombin generation, on the propagation phase of thrombin generation, it is systematically 60% inhibited by rivaroxaban, 50% inhibited by apixaban, independently of the timing and so on. And never, never, never we change a dose, or we had a discussion, should we modify something? Never. The stability is incredible.
It's interesting. That's one of the most important things to come out of this discussion for people to understand, in addition to all of the other things. So that I know we could continue this all day. And first of all, it was a great honor to meet you. It was an even greater honor to have you contribute to our channel and present your work. And I want to thank you. And of course, I want to thank my esteemed partner also for helping us to put all of this together. And I hope everyone that watches it enjoys it. So thank you very much. And I wish you all a happy day and happy weekend.
It's a great honor to be with you.
Thank you.
Thank you very much.